All right, so it's 8:30. Can everybody hear me okay? Let's see if I can go back to this. Perfect. Okay, let's get started just to respect your guys' time. Thank you so much for being here. My name is Tammy Gonzalez. I'm one of the residents working with Motivate MD. I'm going to be talking today about one of my favorite topics, skin cancer. And it's a pretty big topic, so we're going to stay relatively focused for today and work through a case that we see quite often, especially in dermatology residency, but not only in that case, but also all specialties will see a lot of skin cancer, regardless whether you're on the inpatient wards, doing surgical procedures, family medicine, and all kinds of specialties. So it's important to understand the basics about skin cancer. Let's see. So a little bit about myself. Let me close this. Let me put this up here. A little bit about myself. So I actually went to college at the University of North Dakota. I did a medical laboratory sciences degree. Basically everything clinically lab related. I did my MD and my PhD at the University of Cincinnati and also in Cincinnati Children's Hospital. And now I'm doing my dermatology residency at the University of Miami. This is me holding one of the giant avocados that we have here in Miami. And we get these regularly as they fall from the trees. So I'm currently a PGY2. I'm also in a research residency track. So I also finished my postdoc looking at the skin microbiome last year, and then also started my clinical residency this July. So I'm fairly new to Motivate MD. I started about 2 months ago. I do a lot of medical school editing and advising, as well as interview prep. I sat on an admissions board for a long time in Cincinnati. And then I also started working on residency admission boards here in the University of Miami. And I work with the residency editing team, as well as advising and interview prep. Okay, so let's get started here. All right, so this is how today is going to go. We're going to discuss the case. We're also going to go over relevant physical exam findings. We'll discuss the differential diagnosis, fairly focused in terms of skin cancers. And then we'll discuss what the assessment and the plan was for this particular patient. And then we'll dive into some of the details surrounding this particular skin cancer. So what I want you to do is be as active as possible. You can interrupt me. You can type in the chat. Let me see if I can try to get it open too. This is also being recorded, so hopefully that we can go back and reflect on this. And then also throughout the presentation, you can fill out the SOAP note. I'll put the link to the quiz and all of that stuff in the chat in a second here. So let me just put this in here. Let me get it open for you. We'll put it in the chat here in case anybody doesn't have it. And feel free to follow along with this, as well as completing the quiz at the end will be in this. And then any feedback that you have for this session would be extremely helpful. All right. So let's jump into the case. All right. So hopefully you all can see the picture here. Hopefully it's bright enough. So this is a 65-year-old male. He presents with a non-healing sore on the back of his hand that's been growing over the past few months. He reports mild discomfort, but denies systemic symptoms like fever or weight loss. He has a history of significant sun exposure, especially here in Florida. We see a lot of that. And he works outdoors as a landscaper. All right, so what questions do you want to consider when meeting this patient for the first time? Right, Annabella, what kind of history do you want to ask about in particular? Sunscreen use, perfect. Right, any family or personal history, and we'll talk about that. Of course, if the sore has changed over time, shape, color is very important as well. We'll see that with our differential diagnosis. Perfect. Excellent. Let me click through here. So how long has it been there? We kind of touched on that with history. So if it's been there for a few days, we're thinking about certain things. If it's been there for a few months to a few years, we're thinking something a little bit more neoplastic like cancer, as we'll discuss later. So time course is very important, especially when it comes to cancers. Sometimes patients will not remember very much, so it's easy to guide patients into saying, has it been there for days, months, or years? And usually they can say, oh, well, it's been there since I was, like a little boy. Okay, well then if you're 50 years old, it's been there for a very, very long time. Maybe it hasn't changed that much over time. Maybe thinking about different things. Is it growing quickly is another thing. So the time course sometimes is not as clear at the beginning, but we have to ask a lot of follow-up questions to make sure that we're going in the right direction. So let's say we can guide patients in their direction as well by saying like, okay, so if this started last week, how much do you think it would grow over the next week? And they'll be able to provide you with, oh, I think it would double in size over the next week if I were to leave it as is. Another thing about dermatology, so is it painful or itchy? Those are usually the first two signs of any different type of dermatologic condition. So asking if things are painful or if they're necessarily causing a lot of itch is something to consider in the back of your mind. Let's see. So bleeding is another thing, especially as patients get older, they might be on blood thinners. They may also have a history of thinning skin, which can cause bleeding. But if these things are bleeding randomly, that can point you in the direction of thinking about cancers. So when you think about cancers, which we'll talk about later, they're rapidly growing cells. And with that comes increased vasculature. So if they're bleeding on their own, that kind of gives us a little red flag that something else is going on. And then, of course, if they're scratching it or things like that, and they tend to bleed pretty easily, then that's something that you need to keep in mind. All right, so let's jump into the physical exam here. So this patient is a well-appearing 65-year-old male, no acute distress. He's in your office doing just fine. He has a 2 centimeter erythematous scaly and hyperkeratotic, and this should be a plaque, not a papule, and it's present on the dorsum of the right hand. This lesion has irregular borders, it is firm to palpation, and it shows central crusting. The surrounding lesions or the surrounding induration is noted, meaning that it's kind of firm at the base, and there's no ulceration or bleeding that's observed from the central crust. You do a lymph node exam, which we'll talk about later, and you don't feel any enlarged lymph nodes, especially in the axillary region or in the upper arms. You should also check the neck as well. When you're looking at the rest of his skin, you see small, rough, scaly lesions that are consistent with actinic keratoses. And then you also see some evidence of sun damage across his skin, including all of the sun-exposed areas like his forearms, his face, his dorsal hands, like we mentioned here. Even the area you can see he has a nice farmer's tan on his shorts, so his legs obviously caught a little bit of sun. You don't see any other suspicious lesions. And then we already touched on the lymph node exam here. So what from this makes it stand out, or what things are you paying attention to, even though this is a very focused exam? Any thoughts? Absolutely. So the borders are really important. So one of the things that's important to realize is that cancer doesn't really care about how it grows. Usually things in nature are pretty symmetric. And so having irregular borders can seem a little odd and peculiar. Annabella?
I wanted to ask if you can explain the first point under skin, the 2 centimeter. What are those words? I've never heard them.
Yeah, of course. That's a great question. Okay, so for every description that we make in dermatology, there's a few things that we always have to note. So the size is the first thing. So measuring the size is very important, not only for just describing the lesion, but also our management, which we'll talk about later. So there we also describe things in terms of color. So for example, this was kind of a pink or red plaque, which we like to call erythematous, or kind of what we think of like an exanthem or having some type of redness to it. It is scaly, so that meaning that you can, if you were to close your eyes and touch it, you would feel the rough surface of it, so kind of the topography of it. Hyperkeratotic means that there's buildup of skin in the area, and we'll get to that in a little bit too, but that's a way to describe excess skin that's not sloughing off in the normal way. Does that make sense? Or any questions about that?
Yeah,
All right.
thank you.
Okay, so then we're going to keep asking further questions, and this is just getting into his social history here. So this patient worked for a farmer for over 40 years, also spent a lot of time landscaping across his farm. So lots of time outdoors. He doesn't really wear sunscreen that much. That gets back to the question that somebody asked earlier. He recalls several sunburns while he was a younger child. He's currently retired. He spends a lot of time outside, like we mentioned before, landscaping, playing outside with his grandchildren. And like I mentioned, I think I put in that in there twice. He doesn't wear sunscreen. Extra emphasis on that. He lives with his wife. They have 2 adult children, long history of heavy sun exposure, occasional alcohol consumption, no smoking, no drug use. No history of tanning bed use. I know tanning beds have kind of fallen out of favor over the past decade or so, but it's something that you should still ask about, especially when you're thinking about skin cancer. So medical history is also very, very important when it comes to skin cancers. So this patient has a history of high blood pressure on medication, well controlled. Patient also has high cholesterol on a atorvastatin, well controlled. He has a past history of some of these actinic keratoses, which we'll talk about, that were treated with cryotherapy or liquid nitrogen, which we'll also talk about. No past history of skin cancer, and then he has no family history of skin cancer, which is really important as well. And then his medications, like I had listed earlier, and then the patient has no drug allergies. Okay. So these are some of the things that we're thinking about here. And I'm just going to walk through each one of these individually and kind of explain why we're thinking about these things in this context. So the first one that we're thinking about is squamous cell carcinoma. There's multiple different types of skin cancers. Sometimes they can be overwhelming and daunting because sometimes they all just look like pink nodules on the skin or pink papules on the skin. Squamous cell carcinomas, yeah, let me go back to the previous slide here. There we go. I'll give you a second to look at this. Yeah, no worries. All right. So the differential. So this comes up a lot on step 1, step 2, and the reason why these come up quite often is because they're able to just flash a photo and then give a brief description, and then there's a lot of things that they can ask when it comes to skin cancers. So squamous cell carcinomas are proliferations or malignancies of the keratinocytes, which we'll go over in a second. They often form this crusting lesion on the skin. And when you feel them for the first time, they have a thick base. So they're typically very indurated. They're not as soft like normal skin, and it feels like they're almost tethered to the base of whatever surface you're on. So they're a little bit difficult to move. A close, what we like to call a cousin to the squamous cell carcinoma is a keratoacanthoma. The difference between these two is the time course. So keratoacanthomas, which also show up on, board exams and things like that, grow very, very quickly. So they'll start as a small bump, and then the patient will describe, oh my gosh, over the last 4 weeks, I had basically this giant lesion pop up on my hand. Whereas a squamous cell carcinoma is nice and slow. It might take several years, maybe sometimes a few months, but nothing like a keratoacanthoma where all of a sudden 3 weeks later you'll have this giant crusting lesion like this. So the best way to differentiate between a squamous cell carcinoma and a keratoacanthoma is the time course. The other one that often gets confused for a squamous cell carcinoma is the actinic keratosis. And if you've ever heard of these are called, what we call them precancers, because they're very suggestive of sun damage. They typically occur on the scalp. You also get them on the hands as well as the forearms. And sometimes you even have to close your eyes and just rub your finger across somebody's scalp to feel them, because sometimes they're not as red as you see in this picture. So the characteristic for an actinic keratosis is the scaly lesion, but it often doesn't have the indurated base like a squamous cell carcinoma. Of course, the only way to really differentiate between an actinic keratosis and a squamous cell carcinoma is a biopsy, and we'll go through that in a little bit. Another type of skin cancer that you will often see on board exams is the basal cell carcinoma. This one is typically described as the pink pearly papule. So if you see anything like that on an exam, described like a pink pearly papule, you want to think right away basal cell carcinoma. The tricky thing is that in real life, sometimes they also have a central ulceration that can look kind of similar to a squamous cell carcinoma. Sometimes you have to use things like dermoscopy, which is basically a glorified magnifying glass to look at the structures that are deeper down. And then also sometimes biopsy is really the only way that you'll be able to differentiate between a squamous cell carcinoma and a basal cell carcinoma. On exams, they really try to steer you in one direction and give you enough hints within the history to steer you towards one cancer or the other. Basal cell carcinomas like to live on the face, so on the nose, whereas squamous cell carcinomas really can go anywhere else in sun-exposed areas. Another tricky thing that we like to add into the differential diagnosis, as you can see here, is a seborrheic keratosis. So these are what we call age spots. They're basically collections of keratin, and you can see that sometimes they have what they describe as a warty, stuck-on appearance. And these can be all shades of color, so they can be super light, like skin color, and lighter skin, and then also they can become very, very pigmented and be very, very dark, which might scare certain patients as they're told to look out for color changes. And then, of course, in our back of our minds, we always have to think about melanoma. In terms of squamous cell carcinomas, and squamous cell carcinomas are typically more pink or skin colored. The melanoma that we would be able to most compare it to would be the amelanotic melanomas, which are extremely hard to identify, but they don't have the melanotic pigment. And so you always have to just keep high suspicion that any papule could be a melanoma. Okay, so that was a lot. But basically, these are the types of things that you want to be thinking about if you see a pink papule or a pink plaque with some of this crusting as you see here. Okay. So this 65-year-old male, he has significant sun exposure history, has this non-healing erythematous scaly and indurated lesion on the dorsum of his right hand. It's been growing slowly over the past 3 months. And this is most likely going to be a squamous cell carcinoma. And so, like I said, things to be looking out for. So that indurated base, you're going to try to pinch it at the bottom. It's not going to let you pinch it very much. It's going to be difficult to move around and manipulate. Sometimes can cause a lot of pain. Patients might describe itchiness in that area. You're going to see that scaling or that hyperkeratosis, like this buildup of skin over the area. And then these can often ulcerate, like you can see here that it's starting to become a little ulcerated. And then areas where there's more damage, they could also have significant bleeding. Okay, so we'll go into more detail with this. So the next step would be to biopsy. So there's several types of biopsies, which we'll go over. So there's shave biopsies, punch biopsies, and then the most invasive type of biopsy is what we call an excisional biopsy. So triangulating lesions. So basically you're going to pick 3 parts of the body and try to make sure that the location is marked. So for example, if there's one on the face, you want to say that it's, 9 centimeters from the lateral side of the lip. Let's see, 12 centimeters from the lateral side of the eye, and then also the inferior insertion of the ear, which would be like right by the bottom earlobe. You also want to make sure that when you're doing this, you're looking at skin cancers in real life. You want to take as many pictures as possible. Sometimes, especially if you work near a veterans hospital, these people have a significant exposure to the sun and they'll have multiple skin cancers. And so making sure you know which skin cancer is which is important. So pictures can really help. Um, and then consideration and planning for how you're going to excise the cancer after biopsy. So we'll talk about standard excision versus Mohs excision. And then you want to make sure that no lymph nodes are involved, especially when squamous cell cancers involve the face. You want to make sure that you're checking all the lymph nodes, especially as they can progress pretty quickly to involve the face and the neck. If they do have lymph node involvement, that's when you want to involve surgical oncology, radiation oncology, or even medical oncology for chemotherapy options. And then, of course, after you establish that somebody has had a history of skin cancer, you want to make sure that you're still doing your full body skin exams. So once a person has a non-melanoma skin cancer, which would be a squamous cell or a basal cell, you want to make sure that they get their full body skin exams every 6 months for 2 years. So you should see them actually quite often. And sometimes that shocks patients because they think that once the cancer is removed, that they're kind of good to go. But it's really important to establish that just because they had one skin cancer doesn't mean that their risk for getting more has diminished. After that, if they've been clear for 2 years, you can talk with the patient about whether or not they want to continue with the full body skin exams every 6 months or keep going with them annually. Usually we find that patients are become a little bit more worried, and so they want to keep it going for every 6 months. And then, of course, sun protection. So sunscreen is the main one that we think of, but also protective clothing like wide brim hats, long sleeves, sometimes even gloves to protect if you're like driving a lot, longer pants. And then, of course, skin cancers also love the top of the feet. So protecting the top of the feet whenever necessary. And then if one is more susceptible, avoiding the peak sun hours, which is anywhere from 10 to 2 p.m., 10 a.m. to 2 p.m. And then if anybody has like an Apple Watch or some type of device, you can actually see what the UV index is for your area. And that's also another helpful way to kind of gauge how much sun is out at the moment so people can protect themselves. And then, of course, we always try to keep the door open for any type of new spots or lesions that the patient has over time in between the full body skin exams. So it's important to ask when you're seeing a patient for skin cancers or full body skin exams, whether or not they're living with somebody. So it's really hard to take a look at the back. And so if you're asking your patients who lives with you, are they able to take a quick look at your back every once in a while and see if things have changed? That's really helpful, especially for older patients who have difficulty with mobility and difficulty with kind of manipulation to see things in the mirror. And then, of course, reminding people to look under the underwear, to look on the backside, to look at the bottom of their feet, and then, of course, taking a look at their nails is really important as well, especially if with women when we change our nail colors and things like that. If we go to like a manicurist or something like that, to look in between when they're putting on the paint to look for any changes in the nails. All right. Any questions before I keep going with this? Okay. So to get into some of the bigger details here, so who's at risk for squamous cell carcinomas? So squamous cell carcinomas have the widest assortment of risk factors. The ones that we typically think of are sun exposure. We also have things like tanning beds, which we talked about earlier, are really falling out of favor, but some people still really use tanning beds, and so it's important to ask. And then there's a very minimal risk for when we use light therapy with patients that they may develop squamous cell carcinomas. But usually we temper the dose so that they're not at risk for additional skin cancers. Especially if you're working in an area where especially with like veterans hospitals and things like that, we see a lot of chemical exposures due to war. And so it's really important to ask about what kind of exposures they had while they were in combat or in active duty. And then anybody else who may be at risk due to occupational exposure, due to natural disaster exposure, due to other civilians that were affected by warfare, those kinds of things, to ask about environmental exposures, as they can increase a lot of different types of cancers, including skin cancer. So there's several unique risk factors for squamous cell carcinomas. One of the biggest ones that you will encounter, no matter what specialty you choose, is immunosuppression. Now, in the age when we're using a lot of immunosuppression, um, this comes up quite a bit. So anybody who's going to have any type of pretty heavy immunosuppression, considering like cancer patients, rheumatologic patients that are receiving some of these bigger drugs, should be following with the dermatologist to make sure that they are getting their full body skin exams at least annually, if not more often. The other one that you need to keep in mind is organ transplantation. So a lot of dermatology departments have a whole service dedicated to transplant patients. A lot of the immunosuppression that we use um, reduces the immune system that is typically going to fight some of these cancers, or at least provide some type of protection against these skin cancers. Because we don't want the person, the recipient of the organ, to attack the organ that they've been given. We also put them on pretty high immunosuppression. So they're really at risk, and we see a lot of very rapidly progressing skin cancers in these types of patients. Leukemia and lymphoma patients, a little bit more rare, but it's also very important to keep an eye on them because they'll also be undergoing a lot of different types of medications that may predispose them to getting squamous cell carcinoma. The other one that you've probably heard of, which comes up a lot on step 1 and step 2, is the Marjolins ulcer. These are pretty rare, but the basic premise behind this is that it happens in areas where they have chronic ulceration or scarring. So areas with repeated trauma. And the idea is that these skin cells keep undergoing this inflammation and this remodeling, and sometimes that can lead to malignant change causing cancer. And so it's always important that if you're doing a full body skin exam and you see somebody with a large scar or any type of scar, that you're running your finger down the scar to make sure that there's no lumps or bumps in the area that haven't been there before. And these are actually quite aggressive, and they can progress rather quickly. So this one here, you can see that it's a large fungating mass, quite ulcerated, as you can see by this shiny red appearance to it, meaning that basically the skin is open, and that pops up quite a bit. The other types of things that can lead to squamous cell carcinomas in particular are genetic disorders that reduce your ability to repair the DNA that's damaged by the UV. And then lastly, the most important one is going to be HPV infection. So the human papillomavirus is something that we deal with quite a bit, and it can cause warts, but these warts can also turn into something called verrucous carcinoma, which is a variant of squamous cell carcinoma. This also comes up on exams quite a bit because they look like warts. And oftentimes we can freeze warts, we can remove warts. Sometimes you can get that over the counter stuff to take it off. But sometimes if you see a patient that's on a lot of immunosuppression, hasn't had the HPV vaccine before, and then they develop this rapidly progressing kind of warty mass, you want to think about squamous cell carcinoma. And oftentimes these occur on the feet, they can occur on the mouth, especially they can occur on the genital region or the anal region. And they progress very, very quickly, and they can become, sometimes they can become metastatic. So it's really important that if you're seeing a wart that's growing very, very quickly, you want to biopsy it. Okay. So this is kind of like a high level view of what happens basically with repeated sun exposure. I don't expect you to memorize all of this. What the main thing I want you to get out of this is that the actinic keratosis is kind of the warning sign that you're getting a lot of sun exposure. and that patients are going to be predisposed to get squamous cell carcinomas. And that's why we kind of dub them the precancers. The most shallow version of a squamous cell carcinoma is going to be the squamous cell cancer in situ, which means it doesn't go beyond the epidermis or the top layer of the skin. Invasive squamous cell carcinoma is exactly what it is. So basically, it extends deep into the dermis, can also involve things like the vasculature and also surround the nerves. And then, of course, if it goes to the lungs or the lymph nodes, we're considering it metastatic. Otherwise, all this other stuff is beyond the scope. All right, so there's some things that once you see a certain type of squamous cell carcinoma, it puts it in a high risk category, and that's going to change how we deal with these squamous cell carcinomas. So of course, if you can think about it, if you have a squamous cell of the face, you're going to treat that a little bit more aggressively. People are typically going to notice them much quicker. And then, of course, if they're on the genital region, on the anal region, we like to think about the HPV-induced squamous cell carcinomas, and those have to be treated pretty aggressively as well. The last one we also want to think about is the hands. The hands and the feet are really important as well, and those also bump squamous cell carcinomas into the high-risk category. We talked about the borders, so great job whoever pointed that one out. So if they're well-defined, typically it's more of a lower risk cancer, but if they're more irregular, you can't really see the edge as well, that's when we're starting to think high risk. Of course, any tumor at the site of a scar, of a previous injury, if it's growing really quickly, some of these are really intuitive. They make them automatically high risk. And then, of course, if anybody is on immunosuppression, as you can see here, that puts them in the high risk category. Okay. So in this picture on the left, I'm not sure how many people are exposed to seeing biopsies, but skin biopsies are something that you can do in the office. You can do them at the bedside. Typically, most of our consults, when we have inpatient consults, are for us to come and get biopsies of patients that are inpatient. And there's two ways to do it. So there's a shave biopsy, which is going to get most of the epidermis, sometimes the dermis, which is that second layer of skin here. And then a punch biopsy, which is really designed to get the epidermis, the dermis, and also the subcutaneous fat. So really, if you want to see the entire layers of the skin, you want to do a punch biopsy. And then a shave really is a smaller view of the top two layers. So basically, for a shave biopsy, you take a razor blade and you start to make a seesaw motion across the lesion and try to scoop it out. You'll be left with a hole, you stop the bleeding, and then of course this heals on its own. It doesn't require stitches. For the punch biopsy, it's basically like a circular hole, and you just punch down and you twist back and forth. And because that edge there, as you can see right here, is very, very sharp, it cuts the hole. Of course, this requires a stitch afterwards, which most people are okay with, but either way is fine. Lastly, the one that is not shown on here is an excisional biopsy where you just use a blade and you cut it out entirely. That leaves poor cosmetic results and also is sometimes not necessary, so we often don't use that way of excision or a biopsy. In the second image on the right, you can see that typically with a squamous cell carcinoma, once you look at it under the microscope, this top layer here in the pink is all epidermis, so the top layer of your skin. Everything that falls underneath here, if you can see my arrow, is going to be the dermis, which is where your collagen lies, a lot thicker part of your skin. With the squamous cell carcinoma, because it is the cancer of the top layers of the skin, the epidermis, you're going to see a bigger epidermis, so very, very thick epidermis. When you look at the slide too, you're going to see sloughing here at the top of dead skin cells that just don't want to break free. And that's why when you look at the skin cancer with your naked eye, you see a lot of buildup, especially with the with the scaling. And especially sometimes that can be really hard to take off. So if you're seeing a lot of retained epidermis here, that's because this is all malignant change or all cancerous cells that are not sloughing off properly. There's also something that you might see on step 1. I remember I had a question on step 2 as well about the keratin pearls. Because these keratinocytes like to make keratin, and because they're so disordered, they also start to make keratin deep down into the dermis where it doesn't belong. And you'll see kind of these rosettes of keratin, and these are very characteristic of squamous cell carcinomas. So if you see a picture or somebody describes a keratin pearl, or if you see that in a vignette, that's very likely for squamous cell carcinoma. Any questions about that? Okay. Alrighty. So to remove this this lesion, so let's say, I know this isn't the hand, but we'll pretend it's a hand. You can go about it several options. So this is just going to demonstrate a basic surgical excision. But you know what, with some people, especially if they get a lot older, they won't opt for surgical excisions. Sometimes they just will want to keep an eye on it. Sometimes if they're a lot older, are in hospice, are in nursing homes, things like that, you can give it a hard freeze with liquid nitrogen, even though you know that's not going to take care of the problem. But because they're such growing cancers, you can basically monitor them. If it was somebody that was a little bit younger, you probably want to cut it out because then they'll continue to grow and to cause problems and can become metastatic. So to do this, you're going to mark where your cancer is. You're going to make margins so that you're making sure that all of the cancer is cleared. So you leave a little space here, typically 0.5 to 1 centimeter outside of the lesion itself. In order for the area to close like a nice linear scar, you're going to make this ellipse here, because if you ever try to imagine closing a circle, it's really hard to close a circle. You're going to get these little pinched ends that are going to look pretty bad, and then they're also going to be scarred down and kind of irritating to the patient. So we make this nice little football shape. We extend all the way down to the fat, as you can see here, and then we clip out the bottom. So then we remove the whole football shape here. So you can see down here, you have this shiny yellow base, and that means that we've gone all the way to the subcutaneous fat. After that, you go ahead and you put some sutures in to make sure that the deep portions of the dermis are brought together. And then you add superficial sutures to the top to make sure that it's closed pretty tightly. And that's pretty much it. So it's pretty quick procedure. Of course, if it is on the face, if it's on the genitals, if it's on the hands, it goes to a special surgeon, a dermatologic surgeon known as a Mohs surgeon. And they do a few more steps in between to make sure that they get the best cosmetic outcome.